Hello, it's me again, Dr. Charles Modlin, your friendly urologist and health equity national leader and advocate. Today I'm going to talk in this health equity brief about a very important topic you all need to know individually to improve your individual health and that of your family and that of your community. And today's topic is colorectal cancer, something that we don't really talk about often enough. Colorectal cancer, CRC, as it's abbreviated, disproportionately affects African Americans who have a higher incidence and higher death rates than their white counterparts. These disparities in colorectal cancer are influenced by a combination of genetic, hereditary, environmental, socioeconomic, and health care access factors. So what's the incidence, prevalence, and mortality rates of colorectal cancer in African Americans? So African Americans have the highest incidence of colorectal cancer compared to other racial groups in the United States. Death rates are approximately 40% higher in African Americans than in whites. African Americans are more likely to be diagnosed at advanced stages, resulting in reduced survival rates. And that later stage presentation is often related to lack of access to health care, lack of health insurance, lack of knowledge and awareness of the importance of undergoing routine screenings for colorectal cancer. So, as I said, African Americans are more likely to be diagnosed at advanced stages, reducing survival rates. Despite this, colorectal cancer rates overall have been shown to be declining, but have been declining slower in African American populations, partly due to lower screening rates and delayed treatments. So, delayed diagnosis, as I said, leads to a more aggressive disease at presentation, higher rates of metastatic disease. That means the cancer is more likely to be spread to other organs at diagnosis. That can all lead to increased treatment complications due to the late stage detection and other comorbidities and conditions that can develop. Different treatments are required that can result in higher complication rates. So risk factors, as I said, include genetics. African Americans may have a higher prevalence of genetic mutations associated with colorectal cancer. That underscores the importance that we as families speak to one another in our family to become aware of the conditions that are more often tend to occur in our family individuals. Diet can contribute to increase our risk factors. High consumption of red meat and processed foods increases the colorectal cancer risk. Obesity, smoking and alcohol predispose us to developing colorectal cancer and other cancers as well. Diabetes, there's a higher prevalence of colorectal cancer among African Americans who have diabetes also. Again, getting more into specifics about the genetic contributions and hereditary risk. Familial and hereditary factors, again, contribute to increased colorectal cancer risk with conditions such as the Lynch, L-Y-N-C-H syndrome, and familial adenomatous polyposis. That's where individuals have a number of polyps throughout their colon, can increase to higher rates of colorectal cancer. African Americans may have a higher prevalence of specific genetic mutations. As I indicated before, other causes and importance of routine screenings. Colon polyps, often known as adenomas, can progress and develop into colorectal cancer over time if not removed. Early detection through screening is crucial to prevent this progression of cancer. African Americans are less likely to receive timely screenings, contributing to a later stage diagnosis. Screening reduces their mortality rates by detecting colorectal cancer at earlier treatable stages. What are some of the signs and symptoms of colorectal cancer? Persistent changes in bowel habitus, diarrhea or constipation, blood in the stool, bright red or dark, unexplained weight loss, abdominal cramping or abdominal pain, fatigue and weakness, feelings of incomplete bowel evacuation. Again, I've talked about why African Americans have higher death rates. I'm going to repeat myself. Lower screening rates, delayed diagnosis, barriers to healthcare access, including cost, medical mistrust. We've talked about that before in previous health equity briefs. More aggressive tumor biology in some cases, higher prevalence of comorbidities, diabetes, hypertension that complicate treatments. Okay, well, let's get into what are the best screening tests for colorectal cancer. Well, the gold standard is the colonoscopy because it detects and removes polyps in a single procedure. Colorectal cancer does run in my family. My father had colorectal cancer. His sister actually died from colorectal cancer, I think at age 49. And so as a result, because it runs in our family, I myself have already gone through 3 colonoscopies. So again, I talked about how the colonoscopy is the gold standard. It's very, very simple preparation. People hear about the go lightly, the fluid that you have to drink to cleanse the bowel cleansing, the bowel preparation. It's not as bad as what people make it out to be. It's actually fairly simple. There are additional ways to screen for colorectal cancer that have different sensitivities. The colonoscopy is the most sensitive. It can be performed under sedation, of course. Detects 95% of colorectal cancers and precancerous polyps. It's recommended every 10 years if it's normal. You need to speak with your primary care provider to determine at what frequency you should have your colonoscopies. Not everybody, it's not a one-size-fits-all approach. There's something called the FIT test, that's fecal immunochemical test. It has a moderate sensitivity, detects blood in the stool, and requires annual testing. Sensitivity is about 70-80% to detect colorectal cancer. There's a older test with lower sensitivity called the fecal occult blood test, the GUAIAC. It's an older stool test, less sensitive. And then there's the DNA stool test that's called Cologuard. You've seen TV commercials about that. It detects genetic changes in the stool sample. Sensitivity about 92% for colorectal cancer, lower for polyps, recommended every 3 years. There's a CT colonoscopy or colonography test. It's imaging done every 5 years if normal. Variable sensitivity. There's a flexible sigmoidoscopy that only screens the lower colon, performed every 10 years. So again, some of the risk factors for colorectal cancer: smoking increases the risk up to 30 to 40%. If you're a smoker, your risk is 30 to 40% higher. Tobacco contains carcinogens that contribute to DNA mutations in the colon cells. Long-term smoking increases polyp formation and aggressive tumor growth. The best diet to prevent colorectal cancer is a high fiber diet in whole grains, fruits, and vegetables. Low red and processed meat consumption reduces. You should reduce the intake of bacon, sausage, and processed meats. Omega-3 fatty acids, best found in fish, reduce inflammation. Calcium and vitamin D supplementation, and foods rich in calcium and vitamin D, dairy, leafy greens, fortified foods, lower the risk of colorectal cancer. Again, when should colorectal cancer start? Cancer screening start. General populations, screening should begin about age 55. African Americans, it's recommended to start at age 45 due to the higher risk. That recommendation previously was at age 50, but it's been scaled back to age 45. High-risk individuals who have certain comorbidities and risk factors, family history of colorectal cancer should start before the age of 45. Again, if you have a family history, start 5 years earlier. I talked about how colon polyps can turn into cancer. Not all polyps turn into cancer. There's different types of polyps. Hyperplastic polyps are generally benign but require monitoring. There's something called adenomatous polyps, adenomas. They have the highest risk of progressing into colorectal cancer. There's different stages of colorectal cancer. Stage 0, it's carcinoma in situ. The cancer's confined to the inner colon lining. Stage 1, cancer is spread to deeper colon layers, but not beyond the colonic wall. Stage 2, cancer's grown beyond the colon, but not into the lymph nodes. Stage 3, it's involves the nearby lymph nodes but not distant organs. And stage 4 is cancer has metastasized to other organs, liver, lungs, etc. And again, the treatment options depend on what stage of colorectal cancer you have. Treatment includes surgery, removing the cancerous portion of the colon. That's called a colectomy. Chemotherapy is used for advanced stages to shrink the tumors or prevent recurrence. Radiation therapy can be used. Sometimes it's used in combination with chemotherapy and surgery. Then there's targeted drug therapy that would be administered by an oncologist. Immunotherapy is used to treat certain genetic mutations of colorectal cancer. And again, I did indicate already that colorectal cancer can be hereditary. In most cases, it's sporadic, but 5 to 10% are hereditary. Conditions like Lynch syndrome can increase the risk of colorectal cancer. So again, diets that increase colorectal cancer risk: high red meat, processed food consumption, bacon, hot dogs, processed meats; low fiber diets lacking whole grains, fruits, vegetables; high fat, low nutrition diets, fried foods, excessive dairy; high alcohol intake increases your risk. So in conclusion, colorectal cancer disproportionately afflicts African Americans due to a combination of biological, environmental, and health care disparities. Regular screenings, especially starting at age 45 or earlier if you have a family history or high risk factors, is crucial for early detection and improving survival. Colonoscopy remains the best screening method, and a healthy diet, smoking cessation, and exercise can help lower your risk for colorectal cancer. Addressing healthcare inequities is essential to reducing morbidity, mortality, and improving your health outcomes. So again, I'm Dr. Charles Modlin with you for another Health Equity Brief. Please like, subscribe, and share, and spread the word. I'll see you next time on another Health Equity Brief. Thank you.